if there's a patient who's dipping their toe and trying to figure out what's happening, or a provider who's maybe learning more, could you give us a brief overview of what this trifecta is and what it means?
Yeah, sure. Happy to. I feel like I say this multiple times a day, every day in my office, so I'll give it a whirl. But, I primarily see patients with POTS. Patients come to see me because they have dizziness, orthostatic intolerance. And what I've found, in my practice is that most of these patients also have some component of hypermobility spectrum disorder, or EDS. And that can also be a non-hypermobile connective tissue abnormality. So it's important to recognize that there are other things out there that may not be qualified as hypermobile, like lipedema or other underlying connective tissue problems. So most of my patients have that. And then there's this overlap with mast cell activation syndrome, which I think is primarily driven by the disordered collagen that's in the cells of patients with connective tissue disorder and hypermobility spectrum disorder. So when the collagen's not lining up right in the cells, it causes tissues to be more flexible, stretchy, and elastic, but it also allows cells to be a little less stable. And that's where the mast cell dysfunction comes in, and the mast cells get a little bit twitchy and a little bit more irritated in this population of patients because they're not structured quite as well. And the other thing that occurs is that the connective tissue allows sort of this window into spaces where the mast cells exist that maybe shouldn't necessarily be there. And so they get more activated from that standpoint too. So there's this big overlap that when mast cells degranulate, it causes tachycardia and vasodilation and orthostatic intolerance. When you have stretchy tissues, you can have elastic or stretching veins that can cause more blood pooling, that can cause more POTS symptoms as well. So the three are very closely connected.
And you have kind of already touched on why they might travel together. Is there, and I guess what I saw was in the last couple of years, this really started being spoken about more. Is there anything that you feel like started putting things together of why these things travel together, even alongside endometriosis or pelvic pain?
Yeah, so I mean, some people would say that the trifecta is sort of a narrow term, and we should be calling it a pentad or a septad because there's so many other things that kind of go along with these patients. And for me, I think that the kind of overarching theme or the umbrella that encompasses all of these different disorders is that underlying connective tissue problem or hypermobility. And that kind of lends for patients to have these other issues. We know that in hypermobility and EDS, there's a huge immune component. So there's autoimmune disease that occurs. There's immunodeficiency. There's mast cell activation syndrome. And but then we also have a huge overlap with endometriosis and pelvic pain. And in my context, we know that endometrial tissue has mast cells at a higher number than regular uterine tissue. And so we've got overexpression of mast cells in the pelvis when you have endometriosis, and that can cause symptoms to also develop in that capacity. And then there's the issue of pelvic pain, which I see a lot in my POTS patients and often relates to pelvic venous congestion or obstruction of the pelvic veins that causes dilation of downward veins and pelvic vein varices that then causes pelvic pain symptoms along with orthostatic intolerance.
That's so helpful. And I know there's some really exciting developments in the treatments of POTS, dysautonomia, and compressed veins. Could you tell a little bit about how your office evaluates for this and what that would look like for a patient coming in?
Yeah, so this is a new area and a specific area of interest of mine, I think, because I see so much overlap between POTS and hypermobility and venous abnormalities. But we often see patients who come in with pelvic pain and leg symptoms. You could have leg heaviness, back pain, lower back pain. Usually all these symptoms are worse when you're standing and better when you lie down. And we look at ultrasound in the office to see if the patient has a compressed left iliac vein or compressed left renal vein. Those are very common kind of anatomical compressions that we see. We also look at ultrasound of the lower extremities to look for venous insufficiency. So we find that either the veins are stretched or the valves in the veins don't work properly. And so blood's not getting transferred from the feet to the pelvis back to the heart appropriately. And so there's blood pooling that way as well. So we use ultrasound a lot in the office to look for these associated disorders. I mean, this is just one aspect of management of POTS. We look for a lot of other stuff, and there could be other things going on, but that's one thing that we do look for in the office.